Recording. Good evening, everybody. It is so good to see everybody. Thanks so much for spending your time with us this evening. A special little shout out to those folks joining us from La Posada at Push Ridge. Thanks so much for your interest and for being here. So we have a really good turnout this evening. I'm Teresa Jenkins. I am chair of the Public Programs Committee of your League of Women Voters of Greater Tucson. And before we get started this evening, our incoming president is with us, Linda McCabe, and she would also like to welcome you and say a few words. Hi, Linda.
Hi, Teresa. Thank you. Thank you, everyone, for being here this evening. My name is Linda McCabe, and I am the president-elect of the League of Women Voters of Greater Tucson. The League of Women Voters is a nonpartisan political organization encouraging informed and active participation in government. We neither support nor oppose candidates or political parties at any level of government. We do, however, advocate for public policy such as voting rights, non-discrimination, education, natural resources, reproductive rights, civil rights, and criminal justice reform. We have been empowering voters and defending democracy in Greater Tucson for 86 years. We invite all people, regardless of gender, gender identity, ability, ethnicity, or race, to join us as we commit to building a stronger, more inclusive democracy. Thank you.
Thank you, Linda. So tonight, we'll discuss a pilot program that began in 6 states, including Arizona, on the 1st of January of this year. It is called a wasteful and inappropriate service reduction model. It was created by the Centers for Medicare and Medicaid, which is part of the U.S. Department of Health and Human Services. Our speaker this evening will provide as much information as is currently available about this pilot program and address your questions. She's also going to provide us with an update on Medicare for All legislation. You may recall that a few months ago, we provided a program that included the members of National Nurses United. They gave us a presentation on Medicare for All. And the reason for that is because in 2010, the League of Women Voters of the United States passed a resolution asking all leagues to, quote,
Her
advocate
audio is
strongly
off.
for an improved Medicare for all. So we'll give you a short update for that as well. So there's a
There
lot
she
to
is. She's
cover
talking.
tonight. I'm going to ask
Well,
you to
is our
please
audio
mute.
off?
Someone is
No,
talking
because it
over
would have
me.
a line
Could you
through
please
it.
mute?
Oh, I think it's not up.
Who is talking, please?
I think it's Sue.
Could you please mute? Thanks so
Yeah,
much.
they're muted. Okay.
Okay. All right. We got a lot to cover, folks. So let's get going. If you have a question for our speaker, just put that question in the chat and we'll get to as many of your questions as we can. Our speaker this evening is Dr. Eve Shapiro. Dr. Shapiro, welcome and thank you for being with us.
Well, thanks very much for inviting me. And so I'm a pediatrician in Tucson. I've been here for over 35 years, but I've also been an advocate for and health policy issues. I've been a member of Physicians for National Health Program for over 35 years. We advocate for a Medicare for All program, and now I'm on the national board. I've been on the board for the last 2 years, and I'll talk a little bit more about that as well. I also worked on Prop 204. That was in the year 2000. Before Obamacare, it extended access coverage to people up to 100% of federal poverty level. Before that point, people in Arizona had to earn under 35% of federal poverty level, which is basically like $5,000 a year, in order to get access, which is our Medicaid. We were the lowest in the country at providing that healthcare, and that ballot initiative, which hopefully many of you have worked on, uh, enabled something like 250 to 300,000 people in Arizona to get health insurance. Anyway, so I've been doing this work for a long time, and Teresa asked me to speak about this WISeR program, and I'd be curious if I can't really see everybody, but if people could just either raise a virtual hand or a real hand, let me know if you've heard about this program. I see a few. Okay. Okay, great.
Okay.
Oh, a lot of people. Excellent. You are a well-informed audience. So as Teresa mentioned, WISeR, and I did say, but is it, and we'll talk about that, stands for Wasteful and Inefficient Service Reduction. And according to Center for Medicare and Medicaid Services, the problem is waste in healthcare. And this is from their website. Waste in healthcare can not only harm patients, but contributes to up to 25% of healthcare spending in the US. Wasteful, low-value services often have limited clinical evidence of effectiveness, may not align with an individual's specific health condition or needs, or can lead to complications and further unneeded services. Therefore, the solution is the WISeR model that would help reduce clinically unsupported care by working with companies experienced in using enhanced technologies, and we'll talk about those, to expedite and improve the review process for a pre-selected set of services that are vulnerable to fraud, waste, and abuse. So that's their justification. And they are looking for an outcome that will help ensure that people with Medicare receive the most appropriate care that supports the best health outcomes while decreasing costs and easing administrative burden on providers and suppliers who go through the prior authorization process. And we'll talk more about that. Their so-called strategy is to empower patients to partner with their healthcare providers on the most clinically appropriate care plan, protect taxpayers by decreasing fraud, waste, and abuse, and focuses providers on care that has the most impact on the well-being of people with Medicare. Now, this is a program that would apply to people in traditional Medicare. I would imagine from this audience that many of you are on Medicare, and hopefully you're on traditional Medicare and not Medicare Advantage, which we'll talk a little bit about. The Medicare Advantage plan has always used prior authorization, but traditional Medicare did not, except for very high cost procedures. Now, I just wanted to say that most fraud and abuse is perpetrated by providers who bill for services that they never provide. It's not by patients getting care that it's deemed unnecessary. Okay, so they are going to do this process by using enhanced technology to decrease certain wasteful, what they consider low-value services shown to have little to no clinical evidence-based benefit. The technology companies participating in the model will streamline the review of medical necessity for select items and services earlier in the claims process to reduce inappropriate utilization, lower spending in original Medicare. Oh, sorry. And hang on a second. Sorry, next one. Let's see. And expedite decision-making and ease provider administrative burden. That's their claim. Okay, so what that means is they're going to implement prior authorization for at least 17 services in traditional Medicare in 6 states, including Arizona. The model will solicit applications from private companies that currently administer prior authorizations for private health insurers, including Medicare Advantage plans, and it will run for 6 years. Okay, so I mentioned that Medicare Advantage already exists in Medicare, prior authorization already exists in Medicare Advantage. Our group, Physicians for a National Health Program, has done 3 reports on Medicare Advantage, one on cost, one on outcomes for patients, and one on equity. And one of the big issues is how prior authorization affects care. And what the finding was that prior authorization frequently delays or denies necessary care, which is especially costly for older adults with chronic or complex conditions. And an Inspector General report from 2022, I think that's one of the offices that Trump abolished, reported that 13% of prior authorization denials in Medicare Advantage would have been approved under traditional Medicare. So in other words, people on Medicare Advantage are getting denied services that they would get if they were in traditional Medicare. And 18% of payment denials for services that had already been provided also would have been covered under traditional Medicare. So these services then now patients would have to pay out of pocket. And the scope of this has drawn congressional scrutiny, and there have been some hearings about this on part of Congress. In 2024, KFF, which used to be Kaiser Family Foundation, they do a lot of excellent nonpartisan health policy research. They found that 99% of Medicare Advantage enrollees are in plans that require prior authorization for at least one service, and that most of them were services that were affected were advanced imaging, durable medical equipment, post-acute care, with some plans even requiring prior authorization for chemotherapy, for cancer, and skilled nursing facility admissions, where delays could have a huge impact on patients. And in 2024, 89% of physicians reported prior authorization increases burnout. I thought it was interesting that in CMS justification, they make it sound like providers would welcome this because it'll make their lives easier, when that is actually the opposite of what would happen. 35% of physicians also reported they have needed to hire staff members to work exclusively on prior authorization. Now, I'm a pediatrician. Most kids are pretty healthy, and we don't have to do a lot of prior authorizations. But I can tell you, when you do, they take a lot of time and work away from seeing patients. And this slide illustrates that. The AMA physician survey that found that practices spend an hour of 14 hours each week processing 45 prior authorization requests, a mean time of 19 minutes per request. So that would mean, if you looked at that as a global average, the 35 million requests that were reported would result in 11 million hours spent just on prior authorization for Medicare Advantage. And this is the model they want to import to the traditional Medicare, well, that they already have. Okay, and this is the real problem here. The way the participants, the people doing the prior authorization, are paid based on a share of averted expenditures. In other words, the more services they deny, the more money they get paid. And to me, that's a conflict of interest. Obviously, there's an incentive for companies to avert more expenditures by denying more prior authorization requests to increase their compensation. And this is shown to be true in Medicare Advantage. If anyone has any questions, just let me know. Put it in the chat or raise your hand. And again, as mentioned before, the companies who are already doing prior authorizations in Medicare Advantage are the ones who are going to be doing it in this WISeR model. Now, under traditional Medicare, up until now, Medicare administrative contractors were the ones that administered prior authorizations. They had an accuracy rate of over 98%, with an overturn rate. In other words, if they denied something but it was overturned, of about 35%. But private companies administering the Medicare Advantage prior authorization have an almost 82% overturn rate. So that shows that they are denying a lot of services that should have been covered. And this can result in serious harm and death, actual death to patients, because we're talking about people with serious medical problems. Again, I mentioned enhanced technology. And what is that? That's artificial intelligence. So basically, artificial intelligence will be doing the initial screening of the prior authorization requests, and those have been found to have significantly higher rates of care denials. Now, they claim that they are going to be reviewed by a human, but there's no transparency in this process, so we don't really know whether that would take place. And again, the denials in Medicare Advantage were deemed inappropriate at the Department of Health and Human Services in the past. Okay, the company that's going to be doing this process in WISeR, in the WISeR program in Arizona called WISeR. And I just took this from the WISeR website. And if anybody understands what it means, please let me know, because I don't. It says WISeR Symphony is not another AI toolkit, is the governed orchestration layer that turns modular agents into reliable, auditable work across the most complex and regulated operations, starting with healthcare. I think that's just really clear and transparent. Does anybody understand what that actually means? So we don't know anything about this company. And Teresa, when she asked me to talk about this, said, unfortunately, there's really no transparency. We don't know any of the algorithms that are going to be used to determine denials of service. Really, we don't know very much of anything. We do know what the services are, and I'll get to that in just a minute. But again, no transparency. The protocols used to review the prior authorizations are not disclosed, and Center for Medicaid and Medicare Services has not disclosed how they're managing the potential conflicts of interest in the way that companies are getting paid based on rates of denial. Okay, so there's been a huge outcry from the medical community. This was a letter from the state medical associations of the 6 states that are having this program implemented. And it was sent in October. And I know you'd be shocked to learn that they never got an answer to this letter. And I wanted to show it to you, and this is just a part of it, just so that you can see how concerned they are about this issue. Dear Dr. Oz, on behalf of the undersigned state medical associations, we write to raise concerns about the prior authorization pilot under the WISeR model as it relates to Medicare. While our organizations appreciate the aim of CMMS to increase accountability, value, and healthcare delivery for Medicare beneficiaries and reduce spending on services deemed low value or wasteful, we believe the current design of this pilot risks unintended consequences, including delayed care, reduced access, and increased burden on patients and physicians. And I have a copy of this letter if anybody's interested in reading the rest of it. And they also talk about how there's no details on how this program is going to be administered. And then they go on to talk about the burdensome prior authorization processes that I mentioned. They claim that it's going to be good for physicians, but actually the physician community is saying, no, absolutely not. It's going to be very harmful. This was another study that was done by the MA. They found that 93% of physicians reported that prior authorizations causes care delays. 82% indicated the process can lead to treatment abandonment when they had to stop doing the procedure that they planned to. And 29% said that prior authorization had led to a serious adverse event, hospitalization, disability, or even death for a patient in their care. And this is part of the letter that was sent to Mehmet Oz, who's now the head of CMMS. Oh, sorry, this shouldn't be there. There. Then there was a really excellent letter that was sent from, I think, about 20 senators including Ruben Gallego. Mark Kelly did not sign on to this letter, but it expressed many of the same sentiments that were expressed in the letters from the state medical associations. But one other thing they mentioned is that many of the services identified as low value in the WISeR model have already undergone rigorous coverage review through the national or local coverage determinations, along with FDA's safety and effectiveness thresholds, making it unclear why additional authorizations are needed. So in other words, there's already a process in place for traditional Medicare to review these kind of services and determine what's necessary. So it was unclear to these senators why this was happening. That letter was probably 4 pages long, and it had a lot of great information. I have a copy of that if anybody is interested. And then they go on to talk about the burden on physicians and other healthcare providers, particularly working in small or marginalized or low-income settings. It says the model can have providers request peer-to-peer reviews and resubmit denied authorizations. These seemingly well-intentioned safeguards simply create more work for clinicians. And I've done some of those peer-to-peer reviews, and it's kind of a joke. Because usually they approve what you've been asking for, and after you've spent an hour trying to get that to happen. And usually you're talking to a person who doesn't know anything about what you're asking for anyway. So even when it does go to a person, they may not have knowledge of that specific service. Now, I wanted to just show you some of the services that are going to be reviewed. I think, so these are these are mostly done by doctors who see patients with chronic pain. And then there's the wound care ones, the skin and tissue substitutes. So these aren't very common procedures, and I could really not find out how often these occur. Well, arthroscopic lavage and debridement for arthritic knee, that's pretty common. But some of the others are not very common. And so I don't know how many people this will apply to. You could not get that information. I did ask for some stories. As I said, as a pediatrician, I don't deal with Medicare, but there are some stories that were submitted by some pain doctors who do those procedures that would be impacted. And basically, they're listed here, but they're people with chronic pain who needed these services, and that this particular physician said it would be harmful. And also that, and if you see the last one, the procedure that he was going to do was going to avoid opioids. And without that, if the patient had to be on opioids, it would obviously affect their functioning. So this was a way for him to avoid that. So this is an action item if you'd like to do something on this. There's a bill. Now this, as I said, it already started on January 1st. I could not get any information on what's happened. It's only been 4 weeks, and I could not find any information on what impact it's had so far. And it may take a while before we hear anything. This bill was introduced last year to fight against implementing the WISeR program. It was Senate Bill 3480, introduced by Senator Patty Murray. It had 19 co-sponsors, including Senator Gallego, but not Kelly. I think it would not be a bad idea to call Kelly's office and ask him to co-sponsor. Even though the program has already gone into effect, I think it's important to express opinion about how constituents are upset about this. And even if that bill doesn't go anywhere, I think the more co-sponsored it has, the better. And I included the telephone numbers. And I think these slides will all be on your website, so you'll have access to them.
It sounds like her.
Someone,
Oh, I hear somebody talking.
Someone needs to have their computer muted, please.
Hello.
I hear children in the background. Could you please mute?
Then, in addition, so that, as I mentioned, the Arizona Medical Association has been very concerned about this and the impact on physicians and patients, and they are collecting stories. So if you know of anyone who is affected by one of these prior authorization delays, I put her, it's Amanda Scheinson. I put her email on the slide for you, and she would love to get stories because they want to be able to. Legislators like stories because they're not medical people and they like to hear stories. So I think that would be really helpful to see if something can be done. As we mentioned, this is supposedly a 6-year program, but that's not written in stone, and that probably could be changed with enough public pressure. So let me stop there and see if people have questions about this particular program, and then I'm going to talk a little bit more about some of the other medical issues going on.
There's a question about, do you have any idea how these states were chosen? And let me say the states are Arizona, New Jersey, Ohio, Oklahoma, Texas, and Washington. Do you have any idea
No,
why they were
and
chosen?
no, I don't think anybody has any idea. Again, that's part of the lack of transparency, why those particular states were chosen. So I don't know. We were kind of surprised.
And like we said earlier, I think our objective this evening is really to get the word out because as Dr. Shapiro has said, there just isn't a lot of information out about it. I learned about it in August from a New York Times article, and that got me searching and to see what this was all about. But here we are, as Dr. Shapiro said, we're 3 weeks now into this pilot program, yet there isn't a lot of information. Let me ask you this. Um, so if a patient has their care denied, what would be some of their remedies, and would they also be remedies that would be applicable to this pilot program, do you think?
So, these are procedures that I have never done. I don't think any pediatrician has ever done them. But in one of those patient stories, the doctor mentioned that if he couldn't do this procedure, the patient might need surgery, they might need to take opioids. So there might be other covered services, but they wouldn't be the ideal service. They wouldn't be what's best for the patient. So when CMS is saying, oh, we want to do what's best for patients and physicians, that's very disingenuous. Because if they really want to do what was best for patients and physicians, they would continue the current program where they look at high cost procedures and see, are these being done appropriately across the board, not specific patients where you're going to deny care. That is not a way to fix the system. And so yes, there might be procedures that would be covered, but they wouldn't be ideal. And I think in one of the slides it said about abandonment. So that's when the patients just gave up and left and said, we can't pay for this out of pocket, so we're just going to go leave. And so the doctor wouldn't know what actually happened. I assume they could go to another state which didn't have this particular program.
Now, I know that you don't provide any of these services as a pediatrician, but when you look at these 17 services that were selected, does anything jump out at you as to why they might be focused on these?
I think, let me go back to that. I think there might be some that could be could be abused potentially. That it's not always as clear a diagnosis. Like, when do you need to do lumbar decompression for spinal stenosis? So maybe you could say, oh, that person didn't need that procedure done at this particular time. And there may be some evidence that there is some overuse of some of these procedures, but as that other slide, the letter from the senators showed, that there is already a procedure within Medicare to fix that. And I think we run the risk of more denials particularly because of the structure of the payment to these companies that are doing it. I think that's the biggest
Okay.
problem that I see here is that they make money by denying care, and that should never be the process by which we do it. We want to find that information. If it's being overused, let's do a study. Let's look at it in a scientific way, not this sort of a way.
When I read the New York Times article in August, they concluded their article by saying that this was a backdoor into privatization. Do you agree with that?
Absolutely. So as mentioned, I'm on the board of Physicians for a National Health Program. And what we're seeing is a total move towards privatizing healthcare. We want to deprivatize it, and we want to have a government-funded program, privately delivered. But the whole approach is to point it out to private insurance companies. That's what Medicare Advantage is. In fact, it's probably a misnomer to call it Medicare because it's not really Medicare. It's a privately managed program that takes care of people over 65. And and I think it was Mehmet Oz, when he became head of CMMS, one of his goals was to move everybody into Medicare Advantage, that there would no longer be traditional Medicare. So this might be one of the steps in that process. Hopefully he won't be in office by the time he gets through that. But so I think that's definitely the case. And yeah, I definitely think that's what's happening.
Okay. I don't see any questions, so maybe we could move on to talk about Medicare Advantage and then maybe an update on
Okay.
Medicare for All. How's that?
Okay. So so I don't have any slides on that because the other person was supposed to do that part, and she was sick the other day, and I didn't have a chance to do the slides. But basically, what we have found in the reports that I mentioned is that Medicare Advantage has been a boondoggle for the private insurance companies. They make more money from Medicare Advantage programs than almost anything else they administer. And the way they do that, and this was in our first report, I should have put the website it's pnhp.org, and anyone can check out the website. Non-physicians can join for $50 a year, and you can get all our material, which is great. So what they found is that Medicare Advantage, they actually hire people that have a whole group of people that will comb through patients' charts to come up with diagnoses so they can do what's called upcoding. So, you have a diagnostic code. When a doctor sees a patient, they write, okay, they came in for diabetes check, hypertension check, whatever. Then you see people on Medicare Advantage, they have a list of 10 diagnoses. Now, 8 of those may not have been addressed at that particular visit, but they're all listed, and then they get reimbursed at a higher rate than if the patient had less things listed on their diagnostic code. That's the way this program was set up by Congress. And it's been totally abused. And even Congress is aware that this is a big problem because those programs claimed that they were going to provide more services, so they should get more money. So their per capita reimbursement is already higher than traditional Medicare. And then they do this upcoding so that they get even more money. So if you look at their patient population, it looks so much sicker than a traditional Medicare, but it's all paper. It's all based on this upcoding. And it's a really huge problem. And I had a medical student working with me, and she had been in the emergency room. I said, yeah, all of a sudden I started noting all my patients had like 10 diagnoses listed. And she said, oh yeah, we're told we have to put every possible diagnosis down, even if it's not very likely. And it's all a matter of reimbursement. So there's the healthcare fraud, and it's being done by the private insurance companies. And Congress knows, and there have been little attempts to change that. And I think there have even been some hearings lately, and I think even some Republican Congress people are upset about this. and want to change the way they are getting reimbursed. But then to bring that program into traditional Medicare, we've always held us up as sort of the model. It's not perfect, but we say improved Medicare for all because we see this as a really successful program that delivers good care to people over 65. And now it's being whittled down, as you mentioned. The other issue in Medicare Advantage is an equity issue. So part of their mandate is that they have to show that they're providing equitable care. And what that means in practice is they can do a survey of how many patients come from underserved neighborhoods, but they don't actually have to do anything about it. So that's another scam. It's just lip service to meet these requirements when they're not actually providing additional services. And even the services they claim, they say they provide dental and gym membership and all those kind of things. They are providing so little, again, that I think they did a comparison with traditional Medicare, and there was barely any difference in the coverage between Medicare Advantage and traditional Medicare. So that's why I always tell everyone I know who's turning 65, stick with traditional Medicare and a supplement. And now, unfortunately, we have this program. We'll have to see what happens. Anybody have any other questions about Medicare Advantage? Oh, Teresa, you're muted.
Sorry about that. It doesn't look like a question. It looks like a comment or a statement. This is going to impact prescriptions with supply.
I don't think prescriptions are affected by this. I think this is only these procedures, which are mostly in-office procedures or in hospital procedures. So I don't think pharmacy is going to be affected by that.
Okay. And someone's asking for a bill number. I think
Oh, the one that I put up?
yeah, I think so.
Here it is.
Okay.
S3480. And I don't think there was one in the house. I don't think there was a companion bill. So obviously it's not going anywhere. But as I said, I think it's still important to express opinions.
Yeah, and Heather has kindly put that in the chat. It's Seniors um, Deserve Smarter Care Act S3480. Thank you for
Yeah.
that. Yeah.
Okay. Great.
And will the recording be available? Yes, yes. Um, so, how about Medicare for all?
So I was hoping that somebody could just tell me 2 or 3 main points that you guys learned from your presentation by Yvette. I think it was Yvette Flores gave you a presentation. And actually, I was on a Zoom call with her with Senator Gallego's health staff earlier today. But I would first want to hear from somebody in the audience who was at that presentation as to kind of the main points that she made.
I don't know.
Anybody?
Mm-mm. Can we respond? I don't think we can respond. Huh.
So somebody's talking. Did you have something you'd like to say about Medicare for all presentation? Because we can hear you, so that would be nice. So it was Ken and it was Yvette.
Oh, Ken and Yvette. Okay.
Yeah, yeah. And they were really obviously talking about the legislation that they were hoping to get more people, more elected officials to sign on to, and really talking about why Medicare for all would be beneficial. I also want to direct people to the League of Women Voters of the United States website. There is a toolkit there. Because it's also referred to as a single payer healthcare system. And the League of Women Voters of the United States has a toolkit that explains why it is that the League is interested in a Medicare for all approach to health care in this country. And it was really linked quite nicely with what it is that Ken and Yvette provided in their presentation, why it would be beneficial, why it would save money, why it provide better care. So that was really the gist of
Is
the
it?
presentation.
Yeah, so I think when I talk about it, what I'd like to emphasize is that when you're looking at a healthcare system, and it's questionable about whether you call what we have a system, but you look at, to me, the function of a healthcare system is to provide good quality care to everyone at a reasonable cost in an equitable manner. So those are the four kind of pillars of how you would compare a healthcare system from different countries. And if you look at the United States compared to other developed countries, we are the only one that does not have a national health insurance system. Now, there are some countries like in Europe where they have a small private insurance, companies that cover certain things that aren't covered by the state system. But those insurance companies are not for profit, nothing like what we have in this country. And so if you look at the US, our cost of providing care is 30% to 100% more than most other developed countries. So we're way above on cost. And in terms of quality of care, we are sort of in the middle. We're certainly not at the high end. So we pay the most money and we do not get the benefit. And that's probably what they talked about. When you look at certain standard measures like infant mortality, longevity, survival after a coronary bypass graft, those are things that are measurable where you can compare one country to another country. And in all those measures, we fall way below the countries that do the best. And equity is obviously a huge issue. We have a very inequitable system. People with money and in cities can get care a lot more easily than people in marginalized areas and in rural areas. And one of the concerns now with the cuts to the Affordable Care Act and to Medicaid is what the impact is going to be on the rural areas and on marginalized communities in this state. So as I mentioned, I was on a call with Heather Lavoie, who's Senator Gallego's health aide, with Yvette and Ken and many, many other groups, asking him to sign on to the Medicare for All bill, which he did sign on to as a representative. He was one of the early signers, but he has not signed on as a senator. So actually, that's another action item, if you would like, is to ask him to sign on to the Medicare for All bill. You might have that number from Yvette and Ken's presentation. If not, I can get it for you. Ask him to sign on because I think he's under pressure to more stay. Somehow this is seen as a really far out of the mainstream approach to healthcare, even though a recent study by National Nurses United found that I think 65% of all Americans supported a national health insurance system, something like 90% of Democrats and even a majority of Republicans and definitely a majority of independents all supported a national health insurance system. So it is not out of the mainstream, but somehow many politicians see that, and so they're afraid to take a stand. So the more public pressure, the more grassroots pressure that they get from constituents to say, no, this is really important to us, that all these things that are happening to our healthcare system, it's a symptom of a failing system. The problem isn't that the ACA is going to go away going to cost more money. The problem is the way the ACA is structured. It's going to fail because it uses the private insurance industry. And Medicaid is not adequately funded. So all those things are a symptom. of our failing healthcare system and why we need a Medicare for all system, but improve Medicare for all, obviously, because there are current problems with that system as well. Is that pretty much what they covered in their talk?
Yeah, it was. Yeah, it was very good. We had a really good turnout for that one as well.
Okay.
Looking at the chat, going back to the pilot program, someone has asked, can a person opt out of the pilot program?
Oh, no, absolutely not. This is, if you're in Medicare and you're in those states, you're in the program.
And that would, I would imagine, also be true of a physician. They have to participate as well.
Correct. Yes. If you're going to provide those services that are going to be impacted, yes, you would have to go through that prior authorization process. Once we see what happens and we start getting some stories, we'll have more information about the actual impact. This is presumed based on the Medicare Advantage experience.
Well, as you say, I think this is an issue that will have to be revisited by us with you, Dr. Shapiro, and perhaps another couple of months to see what the heck is going on and how this is being implemented. And I don't see any other questions. So I want to thank you very much for taking the time to be with us this evening and for sharing your knowledge about this program and for the great questions that we had from folks. And so, yes, the recording of this program, along with the PowerPoint presentation, will be found on our website in the coming days. So, thank you again, Dr. Shapiro. Thanks all of you for coming out this evening and being with us. We will see you soon and have a great evening.
Thank you.
Good night.
Bye-bye.